All right, good evening and Happy New Year, everybody. I'd like to call the January 9th CMH Program and Budget Meeting to order. And with that, I'd like to read our mission statement. Macomb County Community Mental Health, guided by the values, strengths, and informed choices of the people we serve, provides quality services which promote recovery, community participation, self-sufficiency, and independence. With that, I'll take a motion to adopt the agenda. Motion by Lou, support from Susan. All in favor signify by saying aye. Aye. All opposed? The agenda is adopted. Next item is the hearing of the public. Anybody from the public wishing to speak? You have 5 minutes. Please give us your name and address.
I'll be brief. My name's Owen Fentner. I'm with Macomb Family Services. Our corporate address is 124 West Gates in Romeo, Michigan. Currently, we operate some residential and CLS services within Macomb County. In the 32 years I've been working at our agency, I've never seen the current situation this bad. In my opinion, we have a system crisis. One of the things that we're currently facing is rates that don't support the work that we're doing. Many agencies within the county are running significant deficits that's causing a great deal of financial problems. That, coupled with the situation that we have with staffing, it creates a situation that's basically untenable. What we're seeing right now is many of the providers, most of them all through MORC, are turning in their contracts. When you have 6, 7, 8 providers turning in contracts, that creates a crisis. Our agency is one of those agencies. On October 1st, we sent a letter to MORC indicating that we wanted to terminate our contract. It's now been 101 days, and there have been no other providers willing to step forward and take our homes. Once again, a huge problem. About a year and a half ago, I came in front of the board and I indicated that there was going to come a day where I couldn't afford to accept the contract and that I didn't see any way to undo the contract because it's built into our contract that we can't get out of the group homes unless another provider steps in and says they're willing to run the home. So I'm stuck in a deficit situation that seems to have no end. Thank you.
Thank you. Anyone else for the hearing of the public? Going once? Going twice? All right, we will close the first hearing of the public. Next up is item 4A, a residential lease. I'll take a motion to approve. Motion from Kathy, support from Joan. Do we have any questions on this one? All right, seeing none, I have a motion and support. All in favor signify by saying aye. Aye. All opposed? Motion, Lou opposes. Motion passes. Thank you, Lou. All right, item 4B, residential lease B. I'll take a motion to approve. Motion from Susan, support from Lori. Any questions or comments on this one? All right, seeing none, all in favor signify by saying aye. Aye. All opposed? Lou opposes. Motion passes. Next is item 4C, which is residential lease C. I'll take a motion to approve. Motion from Joan. Support from Selena. Any questions on C? Seeing none, we have a motion and support. All in favor signify by saying aye. Aye. All opposed? Lou opposes. Motion passes. Next item is 4D, which is residential lease D. I'll take a motion to approve. Motion from Susan. Support from Joan. Question from Susan.
Thank you, Mr. Chair. Most of these, I always try to look at the documents and see what the rate changes are. This one has a significant decrease due to the, a decrease in insurance, it appears. Just a quick question, is there something done differently here that we should be modeling with other homes to try and find some room addressing maybe some of the issues that the previous speaker or that the public comment.
Yeah, about 2 years ago, we started to address both the taxes and the insurance piece of our leases. There was not a whole lot that we could do with the tax portion. We're sort of bound by the local community that the home is in. On the insurance side, though, we sort of circled the wagons and we put the word out to our landlords that if there was an excessive amount of insurance, we were not going to accept it. And at the same time, we capped that insurance. We used to cost settle for that insurance, and now we cap it. So it forced many of our landlords, or those that we are now negotiating with, to go out and shop that. Because that was a pass-through cost, there was no incentive on their behalf. So you are seeing some of those decrease. On the other side, some of them are opening a can of worms, and the insurance companies are saying, oh, we've been undercharging you. So it's a little bit difficult row to hoe, but some of them are getting less. The majority are increasing, though.
Okay, so there's no trend analysis, there's no correlation to, types of insurance or insurance providers where we could pool or anything like that?
We have not done anything like that. We spell out in the contract the requirements for our insurance, and we ensure that the landlords are meeting the requirements of that. That's the only prerequisite that we have for insurance.
Has there ever been an analysis, maybe involving the county risk management department or anything like that, to talk about some type of a pooling of insurance for these group homes that, maybe one agency or one insurer would be willing to do a broad-based, multiple business line to help these group home providers or owners to manage that insurance cost and get them under a policy, an umbrella policy or anything?
To my knowledge, Susan, we have not done that.
Do you think that is an option?
It is an option. I can see a couple of drawbacks to that, but I think it is an option.
Okay. It's difficult, I know, for, say, a governmental agency to coordinate or insure. We can't insure it because they're privately held properties, and I understand that. But if there were any way to navigate that, sometimes when you work with different brokers, you can find different arrangements. It might be worth exploring just to see if there's any relief that could be provided to the group home operators.
I can tell you what we have done. So we do have a list of the most commonly used insurance providers. And to GJ's point, where we struggle with is, as you know, we can't tell them who to use.
Of
So
course.
we just subjectively say, here's the most commonly used ones, and here's ones where we've noticed there are trends. The average rate of insurance we pay, if you take them all together, is about $100 a month. So 54 is substantially lower, but we do have ones that are $275, somewhere around there. So we try to use that $100 as at least a indicator.
Yeah, but I mean,
there's so many variables. The difference between a New Baltimore
yeah.
versus, another city is dramatically different.
Right, and I do understand that. 54 to 275 per month, that's quite a range, right? I mean, even given demographics of a region. But I understand that there's probably a lot more that comes to play. I empathize with the residents and the operators of the group homes to try and figure out some way that we can leverage use our size, our ability, our, risk management department to maybe work with brokers.
I think we could reach out to risk management and maybe seek some advice from them. This is their arena. And see if there is something that we couldn't do to better improve upon that.
Yeah, it just seems like sometimes there's some connections in the insurance risk area, that we might be able to manage. I don't know. Something, some stop loss coverage, I don't know. There's got to be something that there's a lot of creativity in the insurance industry that we might be able to leverage. Just a thought.
Thank you.
Thank you.
Lou?
For what it's worth, TJ, years ago, Susan, we reached out to the county. The county was not interested in participating in that. Perhaps the attitude has changed, but they're not inclined to get into that with the group homes. But it's worth re-inquiring if you care to. I'm merely
Yeah.
saying that years ago, we made that inquiry, and they wanted to remain neutral.
And that's understandable from the county's perspective, you know, good point. I was on the board at the, you know, years ago. I don't recall that specific instance, but I know that there's some, you gotta be careful when you're insuring something for private. We wouldn't be able to carry the policy. We would not, and that's something that I would not imagine the county, the executive or the board would, or risk management would wanna take on. But it seems like we have an opportunity to pool here, right? And assist the individual providers by leverage buying. It's just something, and I'm open to the discussion. And I think we do have a different circumstance here, I think, given some of the discussions last month from the executive's office, that they're looking for creative ways to try to put some things in place in terms of cost.
Certainly,
So I'm, yeah,
I'll
do you have more to
pursue-
say? Yeah, do you have more to add?
Mr. Torres, to Mr. Birdie's point, we did about 6 months ago, I did follow up with risk department, and I will do that again. We
Okay.
actually were questioning, is there a different insurance? Do we have to have this high level of insurance? So I think we've had those recent discussions, but it doesn't mean that we shouldn't do it again. And I think Mr. Birdie is correct. They were hesitant to provide a lot of guidance outside of, here's your required insurance that you must have. We can always inquire again.
Yeah, it just seems, yeah, and I'm happy to, you know, participate in those discussions if you think it would be helpful. Thank you.
Any other questions or comments on D? All right, seeing none, I have a motion and support. All in favor signify by saying aye. Aye. All opposed? Lou opposes. Motion passes. Next item is 4E, request for approval of an electronic prescription client agreement as an addendum to the agreement between PCE Systems and MCCMH. Take a motion to approve. Motion by Susan, support by Joan. Are there any questions or comments on this item? Lou?
I'm just concerned what the safety precautions might be of someone getting on the electronic thing and ordering scripts. What's the safeguard in relation to that occurring?
Jim?
You know, we can get specifics on that, but this is run through our electronic medical record vendor, and any safeguard that they would have in place for the protection of that would be also in place with regard to this, because this function actually operates through the electronic medical record. So any of those security safeguards that they have for that would also apply to this. We also have network security within our own network and our own computer systems throughout our system. And we just did a security analysis on that to ensure that we were safe and that we were securely sufficiently protected from hacking. So we have done that analysis, and as I said, this would also be applied to any security that's applied to the EMR.
Well, I'm not concerned about hacking. What I'm concerned about, perhaps you can get an answer before the full board on the item. I'm concerned about someone writing scripts electronically to a friendly recipient. And I think when you're dealing with writing scripts and dispersing meds electronically, I guess I want to know what the safeguard is so that that doesn't happen and we're indemnified against that possibility.
In terms of the hardware piece of it, each physician that is approved to write the scripts through the EMR has a token that without that token, they can't access that portion of the system. We also have monitoring on the back end to see where prescriptions are being written from and by who, and the volume and what drugs, so we can monitor that on the back end as well.
But the data submitted didn't indicate any safeguards, and I was concerned about that. I think maybe we ought to be looking down that stream. As I say, I'd feel much more comfortable if we had something at the full board meeting on this item that, protects that. I understand physicians write scripts, but electronically, that's a different situation. So I'm concerned about that, and I'd like some reassurance.
Can you come up to the microphone? Thank you.
The MCCMH psychiatrists and physicians have been electronically prescribing now for the last 5 years or so. And so what we are requesting for tonight is their ability to prescribe scheduled substances electronically. We are actually required by Medicaid to prescribe electronically because it is actually the safest method that we know now to give a prescription and send it directly to the pharmacy. So there is no third party involved. The consumer is not involved because I can understand your concern with previous prescription writing where the doctor could write a prescription, give the prescription to the consumer, and it could go anywhere. But with electronic prescribing, it goes directly to the pharmacy. Now, what we are requesting for this particular time is the ability to connect our psychiatrists and our prescribers to the pharmacy, similarly to the other prescriptions that they've written before, without having to, because right now, the only reason why we have not been doing that is because our psychiatrists have not been receptive to providing their information to the company that will kind of validate their identities. That they weren't too comfortable with doing that. But the rest of the prescribing world, we have physicians in this body. The rest of the prescribing world has already been doing electronic prescribing for scheduled substances for a number of years. So we're just wanting to get into that system because really at this point in time, that is the safest way in which we can prescribe scheduled substances. By scheduled substances, I mean those that are, like the opioids, the stimulants, the benzos, and so forth, which is prescriptions which are subject actually to maybe being misused if just given to the consumer.
If you're saying that only physicians have access
Yes.
and are writing scripts, that's fine with me.
Yeah.
My concern was that a third party could get on the system and write a script, and you're telling me that's not possible. That
No,
was my concern.
Because there are a lot of safeguards that's been put on the electronic medical prescribing system. And actually, one of the major reasons why we want to make sure that our doctors are prescribing through this electronic system is because now we are being required to report our inquiry into the MAP system, which is our effort to identify all the prescriptions for scheduled substances that are being done across the prescribing world to our particular consumer. And now we will have to report to the state that we're doing that. Right now, we can't really, because with this particular system, the MAP system is already linked to the prescribing system. Right now, in order for us to provide that report, we'll have to do everything manually. And that not only is time-consuming, but is subject to errors. So as an electronic prescription, electronic pulling of information, that makes it a lot safer for our prescribers and as well as the consumers and the organization, because we're going to hold PCE, who is our vendor, responsible for ensuring for the security of the prescribing system and so forth. And so and especially in today's world where we have all sorts of difficulties with the opioid experience and so forth, the better we can safeguard the prescriptions, the better for the consumer and the better for our system. So,
Well, you've satisfied my concern by indicating no third party is involved with the
Exactly.
situation. It's strictly physicians. I'm satisfied with that. Thank you.
okay. Is there any other question?
There might be. Hold on one second. Selena and then Susan.
Before we send things out to the board, I don't know who's in charge of this, but if you take a look at the item approval tracking on the board action request, it lists John Kinch approved this today. So we have to,
Backtrack.
okay, thank you.
Susan?
Thank you, Mr. Chair. So I just am looking at I don't have any questions for you.
Thank you.
I'm familiar with how the scripting works, so it's fine. My question is about the document itself that, it kind of has like the number of months are blank. Is that because it's an addendum to another contract, so it just kind of mirrors that duration? Is that a safe assumption? At the very end, I think where it gives the cost analysis, it just kind of gives, yeah, it just gives, it's blank, in terms of the amount. So I just want to make sure that the duration just mirrors, because this is an addendum to another contract, correct?
That's correct, yeah.
So I think that before full board, that probably needs to be filled in to mirror whatever the duration of the other contract is, so we know what the total expense bottom line is to the budget and where that's going to fit in. That's all. Thank you.
Thank you, Susan. Any other questions or comments on this item? Jim, go ahead.
I just wanted to point out on page 57, there's a description of the authentication process for the physicians and anybody accessing the prescription module. 57 and 58 have a authentication process that's used for this contract. More detail. Thanks.
Thanks, Jim. All right, seeing no other questions or comments, we have a motion and support to approve. All in favor signify by saying aye. Aye. All opposed? Motion passes. Next is item 5, receive and file. There is nothing to receive and or file. Item 6 is resolutions. There are none. Number 7, other agenda items. Did you have any? We'll start with Susan.
Thank you, Mr. Chair. Just given some of the information that was spoken about in public participation, do we have any processes for how we manage vendors or providers that terminate a contract with MORC or any other extension of us, and what we do with that contract? I mean, I just want to make sure that we have some stopgap coverages in what we do in that instance. Do we have any procedure for that?
There is a requirement both in MORC contract as well as our contract that any provider discontinuing, terminating their contract is responsible for the care of consumers until the replacement is found. And so we work very closely with providers that terminate contracts with us, or that we terminate contracts, that we make sure that we have a plan to address the needs of the consumers individually and make sure that they're transitioned to new providers before we finalize that termination. So yeah, there's a set of processes in place to ensure the ongoing care of consumers.
Okay, and so do we have, can we, not now, but can we get an update on what's going on with any contracts that have terminated and get an understanding of what that process is, how that, what you guys do, how long that takes, what are we doing? I just want to make sure that
Sure.
we don't
And-
have any unanticipated gaps.
Right, and it obviously will vary, depending on the
Sure.
volume of consumers that are being served, but sure, we can give you a description of that process. Yeah.
Thank you.
Joan?
Thank you, Mr. Chair. I just wanted to say that we have an unappealed request. So I plan recipient rights Monday, January 28th. 7:30 at the administration building. Appeal. Thank you.
Thank you, Joan. I want to welcome Dave to our, to the 28th. 28th, Lou, on Monday. 7:30 a.m. I want to welcome Dave to his first solo program and budget committee meeting. Did you have anything to say?
Well, thank you.
Just a few things.
Yeah, a few words. Thank you to my staff for their explanations on these items. We did, Susan, to your point, have some internal meetings just today, and we will be following up, and I'll make sure that an update is shared. Outside of that, no, but thank you very much.
Any other board members with any other agenda items? All right, seeing none, we will move on to the second hearing of the public. Anybody from the public wishing to speak? Going once, going twice. All right, we will close hearing of the public, and with that, I'll take a motion to adjourn. Motion from Joan, support from Kathy. All in favor signify by saying aye. Aye. All opposed? We are adjourned. Thank you, everybody.